Okay, welcome to our weekly Q&A, week 3 of our GOPex Growth Challenge. Welcome, welcome. A few folks already have joined us. Well, thanks for joining us this evening or this morning, for those of you joining us from around the world. Um, okay, let's take a look at Simon. Dr. Wong's in the house. Simon, as people are still submitting questions, we don't actually have any questions submitted in advance. Oh, Simon's probably seeing if there's any issues in the clinic. But do submit the questions. So we don't have any questions um, submitted as of yet. So if you have any clinical questions, feel free to type them in the Q&A box or in the chat section. This week in our challenge, we covered case presentation. The first week was all about GOPex, all the different aspects of the basic GOPex exercises, the chewing, the counting. Week 2, we covered the evidence and clinical research from the Stanford Ortho airway plate treatment with infants with removable appliances all the way to the study outcomes of Texas A&M. And then this week, case presentation. We don't have any questions yet, Simon, so no one... actually, Dr. Vashini raised her hand, so I'm going to unmute. So I've invited you, Dr. Vashini, to the panel. Would you like to unmute and ask your question in the panel live? You don't have to turn on your video, but you raised your hand, so I'm assuming you want to ask a question. If that was by mistake, then not a problem. So if I know questions from the panel, everyone's a bit shy. There's going to be some questions there, I'm sure. Yeah, so no questions yet submitted. Simon, do you want to talk a bit about case presentation? That was the topic for the challenge this week. Do you want to share, some of the key nuggets related to what case presentation's about?
Case presentation is a normal process in the informed consent protocols of medicine and dentistry. So the way we operate in the health profession is utilizing what we call the medical model. So the medical model is a progression of steps that we take for every case. And we start with a patient or the guardian presenting with issues, and we question to find out what they would like help with. We then do some preliminary investigations to make what we call a differential diagnosis to get a sense of what problems have to be managed. With the differential diagnosis, we then order appropriate tests so that we can be ready to make a more definitive diagnosis of the etiology or the root cause of the problem. Once we've gathered enough information, we analyze that information and based on our knowledge and experience, we make a definitive diagnosis, so one that we can create a working model of treatment based on. Once we know what the root cause of the problem is and what the issues that we have to deal with, we can set goals. And goals will lead to what we call a treatment planning process. That treatment planning process is one where we discuss with the guardians or the patients themselves all the aspects that we've just spoken about and the recommendations of the treatment management process. We'll talk about what's involved, how long it will take, how much it will cost, what the expected outcomes are, what are the limitations. And once that information is shared in that sequence and in that order, then the guardians or the patients themselves will have sufficient information to make a decision about whether they want to follow the plan that you've provided. So that's the informed consent process. And the case presentation is effectively sharing of information that you as the clinician have gathered about the patient's problem and discussing how you would manage it. The process can be done in any number of ways. Most people tend to provide the case presentation as a verbal discussion, utilizing the records that you have gathered with the various tests. In my practice and in my teaching, I recommend visual presentations, and we normally template the records that we've gathered into a PowerPoint presentation because that's a universally simple and acceptable way of showcasing what it is that you want to talk about. So in my case presentations, I will gather information based on the clinical evaluation of the patients, measurements. We will include the photographs that we take intraorally and extraorally of the patient. We'll include the radiographs and the model scans or impressions. And we'll show the analysis of the cephalometrics and of the model teeth dimensions. And we'll talk about all the findings in hopefully terminology that the guardians or the patients themselves can understand. Case presentations can also be used to showcase examples of other patients so that the guardians or the parents can have a realistic understanding of the outcomes and some of the favorable and unfavorable effects that can happen with treatment. Okay, so we have some written questions.
Yep, that's some questions.
All right, what is the systematic tracing analysis that I use, and do you have an email website to whom we can send our patient cephs? There's lots of systems that are available. There's online services that can help. There's a multitude of different software programs that you can use yourself. If you have no access or currently not using, and you're what we call a light user, then you can use online services such as CephX or any number of cephalometric tracing programs. Just do a web search and have a look to see what it is that you would like. There are ones that are done by AI, and then there are ones that you can trace yourself. I tend to trace my own, and generally the easiest analysis to understand is the Eastman analysis. And so that's certainly one that has good basics and not too difficult to understand. So
Yeah, this was a
that,
question that was submitted inside school by Dr. Christian earlier today, and the answer we give is, well, Simon firstly does his own. He has a software that he got as part of progressive ortho course he did years ago. But I did some quick research, and this is a number of years ago, and I came across fx.com, and our mentorship students, quite a few of them, endorse it. So I recently asked what some of them been using lately, and they mentioned FX was actually quite good, very cost competitive, and there's the different types of analysis, and there's the Eastman that seems to be one that Simon also thinks is good for uh, case
if you
presentation.
want to trace your own, BCEF, capital B, CEPH is also a good one.
Can you spell
But
that
I'm
again, Simon?
assuming BCEF, capital B and then CEF.
.com.
So I think it's .com. I don't know.
Okay.
BCEF.com, yes. So that's one that
Yes.
you have to trace yourself, but some people like to trace their own CEFs. Um, I do that because it helps me actually see what's on the X-ray. All right. Next question. No, question about when we are done expanding. For example, I currently have a 7-year-old who expand upper and lower, and the lower four incisors are erupting nice and straight, and there appears to be enough room for the upper four incisors, although she still has primary incisors and the upper right is just erupting now. There is only slight posterior buccal overjet now. However, there is still no primary spacing between the primary cuspids, D's and E's. So since the 3's are bigger than the C's, but the premolars are smaller than D's and E's, I'm confused on when we know we are done expanding and ready to transition into retainers while the incisors are changing over. So to summarize, how do we know we have enough room for the cuspids and bicuspids, or we have enough room for the incisors, but are 2 years away from the lower cuspids erupting and 5 years away from upper cuspids erupting? How does leeway space play into this planning? So generally, leeway space is the difference of the sum total of the size of the primary canine D and E, C, D, and E, relative to the permanent 3, 4, 5. The canine premolar, first premolar, second premolar in the permanent dentition. The sum total of those teeth is normally smaller than the sum total of the CDE. So, so long as you don't lose prematurely the C, D, and E, then the teeth should fit because you need less room for the permanent canine and premolars than you need for the CDE. Where it gets a little bit confusing is for most people, um, most people, the sequence of eruption doesn't play well with the space that's held by the primary dentition. So in the late mixed dentition, the changeover sequence is lower canines, upper first premolar, lower first premolar, upper second primary molar, lower second primary molar, and then upper canine. And so the sequence doesn't allow you to use the leeway space because the lower canines, permanent canines come through first, and the space that you need for the permanent canine is bigger than what the C space is. So theoretically, even though you've got enough room held by the CDE, the lower canine coming through won't fit because the canine is bigger than the primary canine. And the D, which holds some of the leeway, isn't erupting, isn't exfoliating anytime soon. The same scenario with the upper teeth. The D's exfoliate before the C's. So when the D exfoliates, the first premolar will erupt, but generally it will drift forward and close the C's, that leeway space between the D and the C. And so the permanent canine, which is the last tooth to come out in the time frame before puberty, will be very tight for space because the C space isn't sufficient for the permanent canine. So where the confusion comes from is you normally should have what we call primate space. So primate space is a diastomer that surrounds the canines. So in really good growers, there is always space, excess space everywhere until the wisdom teeth erupt into place. So in really good growers, the E, D, and C are well contacted, so they abut each other nicely. When the 6-year-old moles are up, that contacts slightly. But between the C and the incisors, there should be space. And that space is called primary, what do I call it? Primate space. So when you have sufficient width, you will have room for the permanent incisors to come through. They'll come through precisely in the right dimension so that you've got room for all your incisors, but you usually don't have any space between the incisors and the primary canines. So what normally happens is we have to consider what we call depth, right? AP distance. Depth is as significant as width, which is as significant as height. So the dimensions are width, depth, and height. X, Y, Z axes of physical form. Everyone appears to be tunnel visioned and obsessed with expansion in the transverse without any real understanding of AP depth, sagittal depth, or vertical height. The reality is you can't expand your way out of a depth issue. Right? You can't expand in the transverse and expect to resolve an AP issue. How do we resolve an AP issue? Well, in normal growth, the width is only just sufficient for the incisors. Often, it's a little bit insufficient, like ever so slightly insufficient. And as a consequence of the transverse width generally being very slightly insufficient, the incisors do not erupt vertically down. They are slightly crowded ever so slightly crowded, and are therefore driven to erupt in a very tipped manner. So they erupt in a forward direction rather than a downward direction or an upward direction. So instead of erupting in a perpendicular up and down relationship, because the width is slightly under what the incisors need, they should erupt forward. And that has two purposes. One, it means that they end up ahead of the primary canines, providing primate space. And two, it takes much longer before they contact each other in the occlusion because they're not erupting vertically, but they're erupting forwards. That forward tipped eruption allows a longer timeline for true mandibular rotation with a forward rotation growth path. And that timeline between 6 years of age to about 9 years of age is when you get the greatest growth and development of the chin, assuming there's a closed mouth resting posture driving a forward and upward growth pattern. So your goal is to make enough room for the incisors, but your goal also is to ensure that you tip the incisors and hold a very slight open bite tendency during the eruption process. And that's how you get primate space or room for the permanent canines, and how you get true mandibular rotation or chin development. So it's not just leeway space, but it's also posture and understanding of the eruption sequence and the path of eruption. Right? You're confused because all you know, all you focus on, all you're obsessed with is transverse development. And that is only one of many components of growth and development that needs to be addressed. Next question. Regarding your research paper on hyperdivergent patients, it didn't show much improvement in hyperdivergent patients, but what age are these patients being treated? You're saying you cannot significantly fix hyperdivergent patients even if you start early at 7 years of age. So hyperdivergent, which is a vertical growth pattern or a backward rotation, is the most challenging of all malocclusions to manage because natural growth worsens the vertical component. So as you age, if you are a vertical grower, you get more vertical. So it is normal for vertical growers to get worse in their malocclusion. And so that's normal. The fact that we can't seem to improve that vertical growth is not surprising, but what we are able to manage is we are able to hold it from getting a lot worse. So you can make a vertical grower turn into a horizontal grower, or you can hold a vertical grower from getting worse. Or you can let a vertical grower get worse, or you can make a vertical grower get worse. Right? So that's the spectrum of the options. So ideally, we want to be able to make a vertical grower turn into a horizontal grower, but that's almost impossible to do. Most treatments in orthodontics make vertical growers worse. Right? That's a general accepted outcome of orthodontic treatment. Orthodontic treatment stimulates orthodontic movements. The easiest orthodontic movement is eruption. Eruption adds vertical. So almost all treatments provided in orthodontics increases vertical. That's one of the guaranteed outcomes. A vertical grower, if you increase vertical, grows even more vertical. So when we compare our treatment in the hyperdivergent cohort with untreated hyperdivergent patients, we found that there were not a lot of gains in controlling vertical. They stayed very similar to untreated vertical growers. What my study doesn't show, which everyone understands because all the studies have previously shown that, is compared to untreated patients, we haven't done a lot. Compared to patients treated in orthodontics by dentists and orthodontists, they almost universally get worse. So when you touch a patient, they grow more vertically. When orthodontists treat vertical growers, they get more vertical. When I treated my hyperdivergent cohort, they remained relatively unchanged to people who weren't treated. So it is an amazing gain to be able to treat someone and eliminate the expected adverse side effect. So that's how you should read the study. All right, in a class 3 patient, do you ever put in a lower plate just to hold the lower while you expand the upper arch? If you have no plate on the lower, won't the lower jaw try and track with upper jaw some bit? Okay, so as a general rule in orthodontics, class 3 patients have larger lower jaws than upper jaws. Right? Just general fact. The management traditionally is camouflage. Camouflage, we try to minimize the size of the lower jaw. And that's done by extraction or minimum development. They're keeping very steep curve of Wilson and having retroclined incisors. What we are trying to achieve, if we have the capacity to really develop an upper arch and upper jaw to a large degree, larger than is normally expected in orthodontic protocols, then we should be able to develop the lower arch so that it's full size. So the reality is you might expand an upper arch and an upper jaw so that it overlaps and encapsulates the lower. Right? That's what we want. We want a slightly larger upper than lower. But if we've got a constricted lower, then the amount of development in the upper is limited by how the lower fits. If you're aiming for a more optimum outcome, you want a perfect size lower, and then you want an upper that's bigger than that perfect size lower. So that's our goal in postural orthodontics. we have the capacity to do a lot of development, much more so than would normally be expected in orthodontics. So we develop the lower arch to its full size. So universally, in all my cases, I will use a lower appliance. And I'll develop the lower to be its correct dimension. And then I'll try to develop the upper to be larger than that ideal size lower. So yes, in every case, I will use a lower plate. Because it's almost rare that you'll have a really nice developed lower arch. In some low angle class 3s, you have a very nice lower arch, and if you already have a very nice lower arch, then no, I won't use a plate. But sometimes I will use a lower plate, even if it's a nice lower arch, so that I can add hooks to do class 3 elastics against the upper. So I almost never not use a lower plate. Now, the second part of the question is, if you have no plate on the lower, won't the lower jaw try and track with the upper jaw some bit? So there's this universally expected, um, there's a universally expected um, uh, there's universal expectation that if you expand the upper jaw, the lower jaw will magically sock in and track with whatever you've done with the upper jaw. The reality is that is not something that you can expect to happen. The reality is a child's resting posture determines growth and development of the jaws. Whatever their resting posture is will determine what the lower jaw will do, independent of what you're doing with the upper development. Like it's got nothing to do with each other. They hang their mouth open, your lower jaw will grow down and back. If you close your mouth, your jaw will grow up and forward. So that's kind of independent of what you're doing, because it's what the child is doing that makes the growth direction happen. So if you train the child to have a closed mouth resting posture, then you've got a much better chance of the two jaws tracking, but that's active intervention as well, right? It's not just uh, a random favorable outcome that is predictable. Okay, next question. Can you allow the difference between a NANS appliance and a TPA? So there are lots of different appliances in orthodontic. These appliances are conventional orthodontic appliances used in both phase 1 and phase 2 treatments, and not something that I use in postural orthodontics, but the principle of its use is incorporated into the appliances that we use. The removable stage 1 appliances have a NANS and a TPA component to them. So an NANS appliance is an appliance that incorporates an acrylic pad or button on the premaxilla. And it's a pad of acrylic that acts as an anchorage device, an anchorage component to your device. So if you understand, everyone's probably aware of TADs, right? The mini screws, the temporary anchorages. And the most common place for people to put TADs in the palate is in the premaxillary region, right? They'll put one in the midline or they'll put one on either side of the midline, roughly corresponding to the premaxillar interface. Now, before the invention of TADs, we use either removable appliances or fixed appliances that would also have a palatal component. And Nance developed an appliance where there was an acrylic pad put roughly where you would normally put your TADs in the premaxilla. And it was fixed in place by extensions that usually went to a molar, a band, and an arm extension. And then you would have the acrylic button on the premaxillar, and you would then lock that in towards usually the 6-year-old molars. And that would provide you with anchorage to hold your 6-year-old molars from doing things that you didn't want it to do. So it would just be a way of locking in your teeth from moving around. A TPA is a interlocking of usually the 6-year-old molar. So upper 6-year-old molars would be banded. They would be cemented, and then there would be a bar that interconnected the two molars across the palate. And that was basically bracing the molars and not allowing them to move because you join both of them together across the palate. You could also incorporate a loop into the TPA, and then you could do some expansion and rotation to a minor degree if you want. So the TPA is designed to hold the sixes from drifting forward or to derotate them or rotate them. And they rely on each other holding each other. The Nance appliance is basically relying on that same principle, but adding in an extension to sit against the premaxillar and to have that act also as a third point of stability. So that's the difference. All right, so that ends, I think, our questions on our time.
Terrific. Thanks, Simon. See you next week. I'll just stay on to answer questions related to the challenge. Thanks, Simon. If you've, thank you, Sony, for your question. Let me just get into. Yeah, does anyone have any questions in relation to the challenge? So once again, you can see, I'll just give everyone a quick guided tour. GOPex, evidence and clinical research case presentations this week. Next week, the final week of the challenge, will be covering everything related to the setup appliances and 8-point dental lab. Very, very important. And lab communication. So you, by all means, you can also check out the case supervision excerpts here. So whenever you're ready to do the CE, I've completed the 6-7 hours of training. So if you add it all up, plus the 50 minutes, it's 6 hours, and then you just got to attend the one Q&A to claim your CE within the 30 days of launch. I think August 3rd was when we started this particular 30-day challenge, and you do need to complete the CE quiz. Right, the CE quiz is very simple. You just go to this page here. I think it's like 16, 15 questions. Start the quiz, got to get 80% correct. If not, redo it. Right, simple. It's multiple choice. And then go from there. The next step here is also, if you're interested, the case review. All the instructions are there if you did get the case review. You got 60 days from when you enrolled to send us the records. I know some of you have done so. So, definitely do get around to that. Yeah, and then let's see if there's any other questions. Thank you, Dr. Kana. Perfect. All right, so any other questions? Actually, we've rearranged the, for those who are curious, the masterclass was 60 minutes. We cut it down to about 30 odd minutes to make it a bit more efficient. It's the same core training from facial epigenetics at Stanford. We added this one here that covers the removable appliances, and then origin story, posture literature review, etc., etc. So that's the kind of the free masterclass before you get into the challenge content, right? Which some of it is the same things, the appliances here in depth. All right. So let's see what else is there. One final thing I wanted to mention. I don't see any other questions. We're about to launch probably next week our accelerator program. All right, it's the first time we've bundled this program, which is geared towards those who want to fast track clinical implementation. Right? If your goal is to go from basically first time you've heard of postural orthodontics to starting your first case, and your goal is to do so within 2 to 3 months, this is the program, our Growth Protocol Accelerator. We can confidently treat your own child first, perhaps, and then your patients. Right? So this is the complete clinical system. We've never offered such a bundle before, and so we're very proud to be able to put this together. It is all virtual. It's a virtual kind of mini residency program, 100% online. There's these live Q&As you can join, but also every couple of weeks, the one-on-one mentorship is something that you can upgrade into if you want direct mentorship with Dr. Wong. And there's a bit of an intro here, and then there's a much more in-depth summary of the entire program, roughly 20 minutes. You can kind of, go through. Some of you have already gone through these different videos from this kind of introduction for those who are completely brand new to postural orthodontics. Starting a case isn't necessarily difficult. Finishing it is, right? So that's why, especially on a growing child's face. And once again, we're not talking about any type of conventional orthodontics. This is not conventional phase 1 therapy. It's not learning about putting on braces. So a lot of people get confused that, is this posture plus regular orthodontics? It's a proprietary system that my brother developed over the last 20 plus years. And, for mild to moderate cases, not hyperdivergent type cases that he talked about where you need orthotropics, etc. It's where you can have either a parent track or a clinical practice track. We've realized you don't need as much training as what we had in the past, where it was a minimum requirement before you join our entire full clinical mentorship program, if you only want to treat your own children. But that's why we've broken up into 2 different tracks. So the bundled program is a combination of our 2-day program and what we call our implementation vault, which is really a clinical practice manual of 800 slides from our 2-day program and 97 pages of detailed protocols. Right? For those of you who've done the 2-day intro, you may not have the implementation vault, so that's something that's included in this complete system, our accelerator program, and it includes 2 or 4 of our advanced modules. If you only want to treat your child ever, you only need lab day and advanced phase 1. But if your goal is to treat, in addition to your own children, other kids, then you would need also what we call our clinical day and advanced phase 2. So here, the 2-day intro has 14 hours of training plus, actual bonuses of Q&A, etc. With the advanced modules, you've got up to 31 hours. So all that can be PACE, CE, AGD if you want. We're offering 2 tracks where you don't need the CE. If you want the CE, it's like an add-on. And this, for advanced modules are normally sold individually for $797, $800, or if you get the full bundle of all 4, it's like 2,000. And you can see our regular prices on our website. See if you click on corresponding links. You can see a lot in depth of what the lab day, advanced one, clinical day, etc. is. And what we're doing is we're offering like a bonus clinical case study access. But this is literally everything Simon's taught, including 70 additional hours of clinical practice training. And we've lost count, there's 300-400 hours of additional mentoring calls recorded, transcribed, and searchable in 10 different malocclusion types. So it's a package where easily could be sold for $3,000 to $4,000, and we have a special where it's about 50% off. All right? Why? Because we've realized over the last 6-7 years, it's not about giving you tons of training for the sake of giving it the training. It's to get you to get some mentorship, right? For those who really want to treat with confidence. Right? If you're new to this, this is just this is a specialty. But we're not talking about learning how to treat every single malocclusion under the sun. If you're a parent dentist, you only have to deal with your own child and what their malocclusion presents and how to deal with that. So if you get through just enough of our core advanced training, plus study the relevant case studies that are similar to your own child's, you don't have to study all 300 hours, then this program is for you. Right? And our goal is to fill the next cohort of our accelerator program, our mentorship program. So you can join, the parent track with this mentorship one-on-one in small group setting in $550 per month, or the clinical mentorship, which is anywhere from $1,000 to $1,750. Or you might want to just DIY and get a full 2 years access to our case study vault instead of the 3-month overview. Now, which may be enough for some of you, who are maybe working part-time or, can spend 10, 20 hours a week studying. You can get access. Giving you that 3-4 months access is more than enough for you to get started with your own child. But our goal is to, fill up our next cohort as soon as possible. That's why we're having this kind of special offer. And, it's something that we used to sell for easily, 3,000 plus. It's pay in full just 1,800. Or if you want to add the CE, then it's $147. You can split up into 3 payments. I think it's an extra 10%. Or if you're just a parent dentist and you only want to deal with your own child, then it's just $1,300 plus $97 if you want the CE. Or you can break it into 3 monthly payments of $475. Right? There's a 30-day money-back guarantee. You've got full 30 days to check out the 2-day intro. If you want to break it up into payments, we only release, for example, the 2-day intro initially. You've got the 30 days to review it. And then after the 30-day money-back guarantee, on the second payment, then we release the clinical manual, the implementation vault, or the advanced training. And the third payment is when we release the case study vault. And this is hundreds of hours of training and that 70 hours of clinical practice training. And you get 3 months access to that. Now, if you want to waive the 30-day money-back guarantee because for whatever reason, you've already done the 2-day intro and you know this is what you want, right? Now, traditionally, you would have to go pay at least $2,000 for the advanced training. Here, it's less than that, $1,800. So there's a small discount. If you don't want the CE, if you want the CE, it's additional $147. Right. So either way, you might have done the 2-day intro, and either way, this package is still a better deal than what we previously had. So it's a limited offer. Once we fill the next cohort, or at the end of the month. So we're giving a quick preview. We're not actually, you can't enroll in it, unfortunately, yet. We're still doing some back-end work. So if you end up clicking on this, it will just ask you to fill out your first name and email and phone number, and you'll be the first to get a heads up on it. Okay, so I'm going to share the link in the chat for those interested. Let me just quickly do that. All right, so it's a bit long. posturorthodontics.com/growth-protocol-AC for accelerator-preview. Now, for those of you who are completely new, they want to just treat their own child, but they don't even know whether their child is suitable for postural orthodontics, because it's only for mild to moderate cases that typically take 12 to 18 months of treatment, then you've got this option here. It's the lowest risk, just for $197. You can get a case review. Submit your photos, x-rays, and have Simon review them and then record a 10 to 15 minute video and send it back to you. And it's a one-time payment, and we give you $100 credit towards the accelerator program, right, if you enroll within 60 days. All right, so that's more than fair enough to get some hands-on analysis of your son or daughter's case, or your patient. It doesn't have to be. And then if you add an extra $100, we'll give you a 21-day pass to our 2-day intro program. So for just $297, you get Dr. Wong's eyes on your case, and you've got a 21-day pass for a full 2-day intro program. And your credit is now $150, so effectively only paying $150 to review the 2-day intro and get a case review. All right, so this way it's and it's full money back guarantee, 30 days, so long as you haven't ordered the case review. You've got 60 days to do that, so you can theoretically review our 2-day program. I mean, it was done in the past over 2 days. So if you got a weekend, you can watch 14 hours. So we're giving you 3 weekends to review the 2-day program. So basically, if you don't think it's worth it, it's not for you, get a full money back guarantee. Can't beat that. So something that it's for those who are completely brand new to postural orthodontics. You're a guest joining our Q&A, all the way to those who've done the 2-day intro, whether it's last year or a few years ago. And even for those of you who may have done some of the advanced training and you want access to all the advanced trainings, either way, this price point is a good price point, put it that way. All right, better than what we've offered. So on that note, if you've got any questions, feel free to send us an email. You've got we'll get this up and running probably early next week, and there'll be an extra week or so to enroll. So we've given the link to those who want to review this. You can learn all aspects of our mentorship program through the prospectus that we have given. So there's a very detailed explanation of the mentorship program. So it's all there, all the different tiers of mentorship, whether it's just for your own child or the clinical mentorship where you're treating other patients. The difference between the highest level mentorship versus the mid-tier, you could say, is just the amount of time and the amount of cases you can submit. So you get a lot more one-on-one time with Dr. Wong, reviewing your cases every couple of weeks. And it's very flexible because we have on-demand services as well. So if you have something urgent that is needed to be reviewed in between the 2 weeks, you can do so. And, there's different services like that once you've joined. All right, so there's lots to review there. I won't keep you guys up. It's late at night for some of you in the East Coast. On that note, good night, and we'll see you next week.